Good morning still. I think it's still good morning. I am delighted to be here. Nevertheless, I have a complaint to present to GBCHealth, and that is that I was supposed to be joined here by Elmo, but he stood me up. As many of you might know, PAHO is a 110 years old organization. I've worked some of those years there, only some. It is the health agency of the Americas, and it is the Americas branch of WHO. PAHO works with the countries of the Western Hemisphere to improve the health of the people of the Americas. In spite of having been stood up by Elmo, I'm delighted, actually, to introduce today's session, From Dialogue to Action, how countries are addressing NCDs after the 2011 UN high-level meeting. You might remember that that was only the second time in history that the UN dealt with a health issue. 10 years before they had done it, and it was on HIV/AIDS. So that shows how important this new epidemic is that we are confronting. And because of the UN high-level meeting and the mandates that we got from member states, we created at PAHO the Pan-American Forum for Action on NCDs. And that initiative it's a platform to mobilize multi-stakeholder action on NCDs in the Americas. And we talked a little bit about that in the breakfast the other day. I think I'm also excited that GBCHealth has included this panel on NCDs, particularly as the global community prepares to define what will be the post-2015 development agenda. You should know that today in the Americas, 80% of the morbidity mortality is due to NCDs. But it's not only a health problem, and since we are talking also with business here, I think it's important to hear what the World Economic Forum has said. And they said already in 2010 that NCDs pose a greater threat to global economic development than fiscal crisis, natural disasters, corruption, or infectious diseases. So I think we have the argument there, and it is very, very clear. If we are truly to make a dent in the NCD crisis, it is urgent that we take a whole-of-society approach at a global and at local level, working across sectors and across systems with everybody, all actors in society. And the panel you will hear from here today will speak to just that. Allow me to introduce our moderator, Richard Smith, Director of the Chronic Disease Initiative at UnitedHealth, a partnership with the National Heart, Lung, and Blood Institute that created 11 centers in low and middle income countries to counter NCDs. Before UnitedHealth, Richard was the editor of the British Medical Journal. So we definitely are in for a dynamic conversation. Richard.
Good, thank you very much. Well, I think the first thing I'm going to do is get my panel to come forward so we can really see you, look you in the eye. So I'd like to introduce my panel. So at the end there is Jacob Gale, who's Vice President for Community Affairs at Medtronic and also Executive Director of the Medtronic Foundation. And then we have Evan Lee, who's Vice President of the Eli Lilly and Company. And then Hector Gallardo, I don't think that's quite right, Rincon, who's Director of Operative Solutions at the Carlos Slim Institute of Health in Mexico. And then Gene Berkman, who's come in late, so thanks very much to him, who's a cardiologist at Harvard Medical School and part of Partners in Health. So before I start interviewing these people, I just want to set the scene a little bit. And I think we could argue, I don't know whether it'll come out that way, that actually the private sector potentially has more to offer with this problem of non-communicable disease than perhaps almost any other, both as part of your business and in philanthropic terms. Just to be absolutely clear, we're talking about non-communicable disease, which is increasingly called NCD, just the acronym. So we're talking about cardiovascular disease, diabetes, chronic obstructive pulmonary disease, and some of the common cancers. we're not talking about mental health, and there's a whole debate there about whether we should be. And what these have in common is that they have 4 major risk factors: tobacco, poor diet, diets high in fat, sugar and salt, physical inactivity. I go to so many conferences on NCD where we sit from 8 o'clock in the morning till 9 o'clock at night talking about how physical inactivity is such a risk to non-communicable disease. So if things get a little boring, I'll get you up and we can all exercise a bit. And the 4th risk factor is the harmful use of alcohol. And we ought probably to add the use of biofuels for cooking in closed kitchens in low and middle income countries. Now, these caused 36 million deaths in 2008, which is 63% of all deaths. 80% of those deaths occur in low and middle income countries. And this is a very important feature. In low and middle income countries, 48%, that's almost half of those deaths, occur in people under 70. Whereas in the developed world, in high-income countries, it's more like 26%. When I was a junior doctor in Edinburgh, we used to see lots of people in their 40s with heart attacks and strokes. Now that's relatively rare, but that's what's happening in low and middle-income countries. And if we don't do something, and we are going to do something, then there will be 55 million deaths by 2030. Earlier this week, I was in Bangladesh, where they have recorded all births, deaths, immigrations and emigrations in a place that's famous in global health called MATLAB. So this is in rural Bangladesh, and in 1986 only 10% of the deaths were due to non-communicable disease, but now it's 80%. So it's a very, very rapid transition. It's also a major cause of families falling into poverty, and it has huge economic costs, both in terms of cost to the health system and lost productivity. But the good news is at least half of these premature deaths, and probably more, are preventable. Here in the US, stroke has been coming down for a century, and deaths from heart disease have been coming down since the mid-60s. So it is preventable. And of course we have this problem because of the success in treating infectious disease and in maternal and child health. And in 2007, when I started with all of this, it just wasn't on the global health agenda. It was very hard to get anybody's attention. There were very few resources. There still are very few resources. But then in 2011, as Dr. Klinger said, we had the United Nations meeting, the high-level meeting, which produced a plan and produced targets which will be approved. This is a good time to be talking about this because this will be a major debating point at the World Health Assembly next week, where these targets, which are up there, well, those are the monitoring targets. Maybe we could go back one, just so we can see the targets. So the World Health Assembly will commit itself to a 25% reduction in deaths under 70 by 2025, and then there are a whole series of other targets, like reducing salt consumption by 30%. And the NCD Global Action Plan will be launched. And already there's a debate underway about how will non-communicable disease fit into the Sustainable Development Goals, which are being developed now. And David Cameron, the Prime Minister in Britain, is part of that. And I was seeing the other day that one of the targets is likely to be an overall reduction in preventable deaths, so from non-communicable disease, but also from malaria, TB, HIV, etc. And the phrase that always comes out of these meetings is that if we're going to do something about non-communicable disease, and we have to, then it will be a whole of government and whole of society response. And I think that's very important. This cannot be fixed by the health system alone. So we need departments of finance, agriculture, education, many government departments to be involved, and there's a very important role for NGOs, academia and the private sector, and that's what we're going to be talking about quite a lot. So my reason for doing this is that for United Health, together with the National Heart, Lung and Blood Institute, we have these 11 centres which have been going for 5 years in low and middle income countries. There are 4 in Asia, 3 in Africa, and 4 in Latin America. And they do research, they build capacity, and they advise on policy. And we have a big meeting in DC next April, to which you are all invited. So that's the backcloth. Let's now get into the discussion. I'm going to kick off with Jean, and then we're going to have a video of the minister from Rwanda. But Jean has done a lot in Rwanda. So Jean, tell us what you've been doing there.
Thank you, Richard. Well, So in Boston, I'm the director of the program in global non-communicable disease and social change at Harvard Medical School and at Partisan Health. And we've been working with the Rwandan government since about 2006, supporting their efforts to provide equitable health care to the population there. And what we've really seen through that lens, as well as other sites that we're working, is really the face of non-communicable disease among some of the poorest populations in the world. And really the face of this, in some ways, is similar in terms of the kinds of responses that it can benefit from, but is also different in that it's often not linked to these kinds of traditional risk factors like tobacco, lack of physical activity, or poor diets. And these are things like rheumatic heart disease, type 1 diabetes, Burkitt's lymphoma in children, asthma, epilepsy. And we're convinced that there's a huge opportunity that's been created by particularly the UN high-level meeting in 2011 to open the window on addressing these kinds of gaps in the health systems of even the poorest countries. And Rwanda is very much committed to this. It sees basic health services and addressing these conditions they see as basic health services that are part of the rights of Rwandans. And furthermore, they're convinced that in responding to this, for low-income countries in particular, it's going to require sharing lessons and collaboration amongst low-income countries. So recently, with support from the Medtronic Foundation, we formed, in collaboration with Partners in Health and the Rwandan government, an initiative called the NCD Synergies Initiative, which aims to bring together a group of 7 low-income countries that have populations that are really the kind of populations that are the focus of the Millennium Development Goals, countries that have large populations living in extreme poverty, under $1 a day, to work together on having excellent national strategic plans that are really a kind of call to action and a way to mobilize financing ultimately for these issues, and also to share lessons amongst themselves. We're having the first network meeting of this initiative in Rwanda, July 15th and 16th. You're all invited, as others have said, and there's also some information about the initiative. It's certainly looking for partners. There are lots of opportunities for partnership from the private sector in this work. Some of the initial countries that are involved in the initiative are Liberia, and there's another country there are preliminary discussions with that I won't announce here, but that's likely to be announced at the meeting in Rwanda as well. So we're very excited about supporting this and think that there's a huge potential to address these kinds of NCDs even in populations that are extremely poor.
Jean, just before we go to the minister, because I hear what you say about this is a slightly different kind of picture in a very poor country like Rwanda. But as the WHO points out, the underlying drivers are globalization, urbanization. So I imagine the kind of risk factors I talked about are beginning to emerge in Rwanda as well.
Yeah, absolutely. I think that there's also an opportunity, to prevent emerging disease burden, particularly in older populations as countries become more affluent and emerge out of extreme poverty. I think that the other important message here, though, is that there's no reason to wait. There's no reason that the endemic problems that are not linked to those emerging risk factors that are still non-communicable shouldn't make it onto this agenda. And if you look just very practically at the diseases that we're talking about, an agenda that focuses on lifestyle risk factors alone just will not address those problems. If you look at the cancers that we see in Rwanda, they're just simply not linked to tobacco, as is the case in a lot of rural Africa. You're looking at cervical cancer, breast cancer, Burkitt's lymphoma, Kaposi's sarcoma, the list. The cardiovascular disease that we see is rheumatic heart disease, cardiomyopathies, tuberculous pericarditis. We see very little coronary disease even in registries from Soweto, as we know. So there needs to be both an agenda to prevent emerging risk factors, but we have to learn from the experience with HIV and TB that we can't sacrifice an entire generation of people that are suffering from these conditions while we wait for economies to improve.
Sure. And I don't think anybody's suggesting that. Mm-hmm. So now we're going to have a video from the Minister, Anita Asimwe from Rwanda, and I think,
This is Agnes Binagwahu.
All right.
The Minister, the other...
Right, sorry. So I think when we get to heroes, she may well be one of them in the future. So I hope it's about to appear. And she's going to describe what's happening there in Rwanda.
Hello everybody. I'm so glad to be part of this conference, even though it's by video. Just know that I will have loved to be with you physically. The theme of this conference is very important for a country like Rwanda, but for all countries around the world. It's very important to start to tackle non-communicable disease seriously in an integrated manner, based on science and on evidence. In Rwanda, we have non-communicable disease in our health system strategic plan since 2008, but it's just now that we have successfully contained the infectious disease that we can implement it. We have the objective to integrate it, the fight against non-communicable disease across all the health sector, started at community level. For the time being, we have 3 community health workers in each village. We plan to add 2 more. Those 2 will be in charge, a man and a woman, of prevention, care and treatment of non-communicable disease at village level. There will be those who do the sensitization for prevention, the sensitization for good follow-up of the treatment and good adherence, and also help us to do diagnostic on time and explain to the people what are those diseases that are not really part of the understanding of our communities so far. In the health facilities at all levels, starting by health centers to hospital, to referral hospital, we want to create units and departments with skilled people we are going to train. So this is the integration that we are going to do in our country. I want also to say that those 2 extra community health workers will also take care about chronic disease and end of life, to avoid people to go and die in hospital when we cannot do anything more for them. Now, integration in the region and collaboration with other countries. We don't want to do that alone. We want to have the opportunity to share experience, to take lesson of what we have done, and to succeed together. And this is why it is very important to have an initiative like Synergy Initiative. Based on science, several countries, we are going to come together and do better strategic planning, better response to non-communicable disease, and I take this opportunity to thank our partners that have accompanied us up to now, and also Medtronic that join us now in that fight for non-communicable disease. Countries like our countries need absolutely to work on that really now, because we have the burden of the non-communicable disease of the developed world, plus the one linked to the countries where we are living. I want to talk about cook stove, where a woman gets sick, lung disease, heart disease, because she used an equipment that it's not good. And also the baby she has in the bag that got those problems. So we have the pollution. We have to tackle it now before it makes our environment totally not good for us. And I'm sure that during these conferences, you are going to discuss all of those. And all the non-communicable disease we can tackle right away. And it's my great pleasure to wish all of you a very good conference. Thank you.
Good. Well, thank you. So, Jacob, the Medtronic is working on this Synergy project. Tell us a bit more about it.
Well, yeah, sure, thanks. And I first of all, good afternoon to everybody. I'm really glad to be able to see and to hear the minister talk about what is happening in Rwanda. It's very consistent, I think, with, first of all, why Medtronic would even get involved with something like this. Is a mission-based company. I mean, Medtronic is truly on a mission. Its goal is to alleviate pain, restore health, extend life, and to make sure that anybody worldwide who needs can access. And I think that's exactly what we're seeing here in Rwanda, is trying to be able to extend care for non-communicable diseases to the district level. And what they've been able to demonstrate is with $1 to $2 more per person, that the basic services to be able to manage non-communicable diseases, including in many cases the actual medications that may be needed, can be done with just a marginal cost when you build upon the infrastructures that have already been built, whether they're built for HIV, maternal and child health, immunization, other kinds of health issues. Instead of building yet one more vertical stream or vertical process, we really have to strengthen the health systems that benefit them all. And so I think that the example that we see here is not only one that is encouraging for other like countries, south to south kind of transfer of knowledge and leadership, but really have some very important implications for other, perhaps more industrialized countries as well. And so I think the Synergies project is about that, is being able to share lessons, sharing what we are learning in different contexts so that we each help each other. It's all about local ownership and global partnership.
So you mean some of the learning in Rwanda might come back to the US?
The US, Western Europe, anywhere else, I think they're going to be relevant. And when we see the same issues that are occurring there are happening in countries like the US and elsewhere, it's important that we shift tasks to the people who can reach those in need the greatest. Frontline health workers, for instance, and whether we're talking about community health workers, emergency responders, primary care physicians or nurses, that they are more likely and well qualified to be able to help deliver services and to build that bridge between underserved populations and a healthcare system that can help them manage their own care.
Yeah, I mean, I think that message that we don't want another vertical program is pretty important. I mean, even AIDS and TB, which are so closely related, tended to run as parallel vertical programs. So let's move now to Mexico. Tell us how's Mexico going about this problem?
Well, thank you, everybody. My organization pursues for the search of innovation and solutions to the global problems. It is good to know that you guys are facing the same problems down there, and I think it's like two faces of the same coin. Just imagine my country, just a few weeks ago, our president in our country just launched a huge campaign against starvation as a major policy, as well as he did 2 weeks ago against obesity and diabetes. So as my country, other countries in Latin America as well are trying to defeat this double burden of disease. So what is our organization trying to do in a synergy with different organizations is to pursue and the search for solutions for those problems. Innovation is the key, and as I had said before, primary healthcare systems, at least in Latin America, at least in my country, I think, has to be re-engineered. The system that we have was modeled 60 years ago, where the epidemiological profile was completely different. And so we could not have different results using the same system. And that is how we pursued for new evidence in order to change public policy. That's what we are doing. In the process of re-engineering primary healthcare to face this new epidemic, this new challenge, we really think that it's not a new program what is needed. It's not a new vertical program as we did with polio, as we did with measles, because NCDs challenge us to develop a new model of care. And that's what we are doing. That is what Casalud means, and that's what we have been exploring for several years, not only in Mexico, but in Latin America. And Casalud is enabled through technology, but we understand that technology is not enough. We understand that not necessarily, as we said yesterday, right here, high tech not necessarily means high impact. And we have understood also that tech is not a toy, it's not a gadget, but you have to work with that embedded in a model of care. And that's what we're doing. So Casalud is the model, is the answer, the systematic answer that we have been able both to implement and prove and test that could eventually work re-engineering the primary health care to face the burden of disease of NCDs.
Because one of the things that Georgia Lane, who was the former Director General of PAHO, says is that, you know, you've got, ideally you want the President or the Prime Minister to take responsibility, because if you're going to have whole of society and
Right.
whole of government, you want the person at the top. That's happening in Mexico.
That is happening because it's got to be a multi-sectoral approach. It is not enough. I mean, as we have been discussing those days, it's not enough what you can do from the health sector. You need the educational sector to help us. You need the industry to help us. You need the regulatory system in each country. And in order to do that, you have to have very strong leadership. As is happening right now in our country. And of course, we from the NGOs organization, we can help a lot. Usually the ministers of health are very busy doing emergency things, and they don't have time to do important things. So the synergy with NGOs and people who is willing to work with them, through them, in a wonderful synergy, will allow us to eventually succeed in facing this tremendous challenge. So Casalud model is based in 4 pillars, very quickly. Pillar number 1 has to do with real availability of essential drugs. You can imagine such a severe problem is, at least in our countries, availability of drugs to treat diabetes in the primary healthcare setting. No technology around, no way, even though we have the money to buy it. It's a pity the amount of the availability of very simple drugs, even though we have the money through Seguro Popular to buy them. The second pillar has to do with continuous development of professional abilities. You can imagine what we can do through e-learning to teach not only GPs and nurses, but the whole team in the primary healthcare area. Having said that, the third pillar is also very important, and it's around tools. Give me the right tools, and I can do the right job. Most of the time, we don't give the right tools to the health workers and the primary healthcare, like medical calculators, like electronic medical records, like very simple tools. And last but not least, let's have, in the fourth pillar, let's have the citizen. Let's have the people to be accountable of their own care. It's not like a polio area in which you just get a shot and then the immune system will do the job. Now you need real commitment from the citizen to take care of their own lifestyle. So those are the 4 pillars in which Casalud is based. And up to now, although we are in the pursuit of that evidence, we are having a systematic way of implementing this puzzle.
Good. That sounds tremendous. Evan, tell us about what Eli Lilly is doing.
Sure. At Eli Lilly, I oversee the MDR-TB and the NCD partnerships. And the NCD partnerships really represents an evolution towards the concept of shared value, which many of you are familiar with. And we have country-based activities in 4 countries: Brazil, Mexico, where we work closely with Carlos Slim, India, and South Africa. And one of the things to highlight, and I was just looking at the screen to remind us of the theme of this, is that although you've heard the previous speakers talk about the integration on the front line and the primary care where NCDs will first be detected, it's really also important to understand and that we take into consideration as a partner when we work with organizations in country is the differences between countries and where they're at. So for example, in India, the government has made a major commitment to diabetes and to tackling NCDs, but there's a lot of work to translate high-level country targets into policies and action plans. In a country like India, which has 32 states, each with a population of 30 to 200 million, translating that into the particularities of each state. And so our project there is very much focused on establishing a model for diabetes awareness, early treatment, and good follow-up that's adapted to the needs of where India is at. In Mexico, for example, they already have a primary healthcare system, as Dr. Gallardo was saying. And here, we brought in we're bringing in some rigorous impact evaluation. And also I should add, and this is very consistent with the concept of the shared value, we deployed some of our corporate expertise. We brought somebody in from our Six Sigma organization to help standardize the process of Casalud implementation. And so it was an example of not just funding, but real corporate expertise being contributed. And then in Brazil, Brazil has a very strong Pharmacie Populaire program, but there's still some gaps that haven't been addressed in terms of the risk of type 2 diabetes in women who've had gestational diabetes and in the care of type 1 diabetes. And lastly, in South Africa, where there are some organizations that have very strong community-based support for HIV and community networks, our work there is focused on organizations that can leverage that to now tackle diabetes and NCDs.
And are you involved at all in projects to try and stop people developing diabetes? Or is it primarily active once people have developed the condition?
Well, as a treatment-oriented company, I will say we're mostly focused on people who have the disease. But I would add that, in line with what people have heard earlier, that I think the issue of tackling prevention is very much outside the healthcare sector. And while the private sector be engaged, I was just thinking yesterday when we had our briefing, I mean, we have an example here in this hotel, for example. If you wanted to take the elevator back and forth between the mezzanine and the lobby, you can go find the stairs, which are behind a door and are hard to find and are kind of not very attractive. And I think that's really an example. It's just a few meters down the hall of where it's much more than just the pharmaceutical or even a healthcare sector-based company with Medtronic of having to engage and really fostering the lifestyles, and also the opportunities for other organizations, other companies to be engaged in other sectors and some of the needs.
Right. We're going to give you an opportunity to join in the conversation in a minute, but before we get there, I mean, all around the world there are governments preparing plans to do something about non-communicable disease. It's one of the things they're required to do. And there's a big issue, where are you going to invest your resources? And WHO sort of has 4 levels. There is the treatment of people with established disease at the top. Then underneath that, there's the sort of metabolic risk factors like hypertension and raised blood sugar. Underneath that is sort of lifestyle activities that Jean was being slightly critical of. And then underneath that is the social determinants, trying to create healthy places and healthy communities. Where would you put your money? I think you've answered the question already to some extent. I'd like us to talk amongst ourselves, because it's kind of tricky, isn't it?
Yeah. Well, I think I think the answer is obviously going to depend on, the countries, and this is something that, will vary from country to country. I think that this exercise right now that countries are being encouraged to do in terms of making national strategic plans is extremely important. And one of the things that we're hoping that the Synergy Initiative will allow is that if you're going to be, say, funding, and really the question is funding. There's no large-scale financing for this for national implementation. In fact, what you see often is these kinds of partnerships, in fact, with the private sector that are maybe at a health center scale or at a district scale, that those initiatives be aligned with national plans, so they're actually part of something that can grow and can scale within a country, however those priorities were set. So, for example, if you're starting an initiative in a district, and that's all that there's funding for, that there's a vision that district become a training site, that's really a place that, as more funding becomes available, that others can go to that site, get trained, expand to other districts. I think that the WHO exercise in terms of setting high-level priorities, it's important, but it also very much has to be customized at the country level. And I don't think that we're actually. I think that the priority setting process involves a lot of things, including vision, strategy, inspiration, things that we often don't think about. I mean, we don't know really the horizon for funding for this. So to say that we're maybe that having an initiative to treat a very specific disease, say for example breast cancer, that's very symbolic. may be able strategically to bring attention to this and to mobilize funds. So I think we have to very seriously take those kinds of considerations into account when talking about priorities.
I mean, within our network, we have, we talk about, would you want to kind of invent a system like the ones we have in the US or Britain? This is an opportunity, really, to do something a bit different. That's much more about prevention, public health, primary care.
Well, I was going to just say in response to your earlier question, I mean, your question about where would you put the money, I think that still speaks to a sort of a very top-down, either the government or donor-led approach. But really, a lot of these things will be addressed, or some of them could be addressed. The social determinants, a healthy economy with, companies that are productive is going to address some of that. So I think, for some of what those four components, some of it might be alignment. So aligning national policies to favor the development of foods or tools that promote healthy lifestyles, but are still taken forward by a vibrant private sector. And then, other components will involve the top-down funding and the government. So it's not where you put your money is, but it's some cases it's alignment, in some cases it will be funding allocations.
But do you worry that if you don't think about this, then, I mean, sickness systems always trump health systems. I mean, we have a national health service in Britain. In reality, it's a national sickness service. That's where all the expenditure is.
That's exactly right. And to answer your question, we have discussed a lot and we have learned a lot from previous experiences from other systems. And to us, the answer has to do with three words. First, strategic thinking. For example, if you are to teach community health workers or nurses or GPs, you'd rather go e-learning. The outreach is just incredible.
But you were just being critical of technology.
Well, as soon as you use it in the right and the proper way, it's not instead of face-to-face teaching, but you can advance a lot through e-learning. Having said that, let's go to the second point, which is being proactive. Up to now, most of the ways that I have seen all around the world to face diabetes and other NCDs is up to the point in which the patient is already diabetic, meaning the 126 dilemma or paradigm. What about pre-diabetes? What about pre-hypertension? What about pre-obesity? This is the real opportunity. So being proactive is not waiting here to the new diabetic patient to come, but acting 10 years before with pre-diabetic people. Maybe some people around this table, this meeting room, is already pre-diabetes, is not aware of that.
They will be, we know that.
Or pre-hypertension.
Sorry,
and third, last but not least, let's just have common sense. Let's go where the people is. As we did in the subway of Mexico City. In the subway of Mexico City, there are more than 5 million people commuting every day. Let's move health services there. And let's do a triage to early detect both pre-diabetes and pre-hypertension and the subway. And what we have found there is 18% of adult population in the subway is pre-diabetic and they are not aware of that. And up to 30%.
So wait a minute, what are you going to do with them? So you're encouraging people to be recognized as pre-diabetic.
Exactly.
What are you going to do then?
Now we can use technology back there. So for example, we have a gorgeous system through SMS and mobile technology to change lifestyle modification named ViveSanoNet. And if you find him or her that is already sick, you can send through a primary healthcare system, and again, you can use technology for continuous of care. Not been waiting every month or 2 months for an appointment with the doctor, but use the daily possibility through technology to raise awareness and change lifestyle.
Richard, I think that when you really look at the fact, we oftentimes in public health talk about the search for the silver bullet. And even though I hate that analogy of a bullet being something that brings health, nonetheless, there is really no such thing as a silver bullet. Because even with immunization, we learn the fact that you can create the best vaccine possible. But if you don't have the social circumstances for the acceptance of it, if you do not approach the barriers, both the logistical barriers, the cultural barriers, the educational barriers, then that so-called silver bullet will not have any impact. So I think when we talk about where we put the money, there's no one choice. we have to realize that it's the longest spectrum of care. And
So that's not you just avoiding the question.
No, so
you
it's not
can't
just
put
me
it in
avoiding
several
it.
places
Right,
at
right.
once.
I think we'd want to prevent disease wherever we can. The reality is disease is going to occur nonetheless. And so I think people have the right to be able to pursue health in whatever state they find themselves, and we have to make sure that we can approach it at all stages.
Yeah, I mean, Gates on the whole stays away from non-communicable disease, and I think it's partly why there is no silver bullet, as you say, but also that it is complex and long-term, and often, not always, but often, a slow return. It doesn't come immediately. Why do you think Gates stays away from non-communicable disease? You've got a simple answer. Okay, well maybe this would be a good point to start involving you in the discussion. So this man here has got a simple answer to why Gates, perhaps you're from the Gates Foundation, are you?
No, I worked for him in a former life.
Can you tell us who you are?
I'm Dennis Gilhooly. I was Vice President of Teledesic, which is the satellite project works in the sky. The reason Gates is skirting both technology, information and communications technology, is because he doesn't want to see a conflict of interest from Microsoft. But NCDs he hasn't come to grips with yet. And we've got to get him around on it. Because Bill's mentality essentially is he will change the world in one area and then move on to the next. So that is actually what's happening. So his focus is on infectious diseases and on research and development in a most focused way. But I have a question for the panel, because the Broadband Commission on Digital Development, which I actually wrote the report for and put it together, the two co-chairs were Carlos Slim and Paul Kagame, which was an extraordinary dynamic. You got the richest fellow in the world, but apparently he's not now because Bill took him over today. And you had Paul Kagame, who's a complete visionary in terms of restructuring the whole of Rwanda for information and communications technology. I spoke to Jean actually earlier on this. The whole thing with NCDs is that if you don't go to remote diagnostics in the home to actually reduce acute admissions, we are not going to see the cost savings that we have to see as the public health sector moves towards bankruptcy. And do you guys actually understand this technology, and how are you going to employ it in your workplaces?
Okay, well actually what we would like to do is we'd like to give as many of you as possible a chance to ask questions, make comments. So what we'd like to do is, let's collect a few here. So you can be thinking, how much do you guys know about digital technology? We'll find out in a minute. So other questions, comments? I'll get you all up to do physical activity in a minute. To enliven everything. Over here. Tell us who you are, please.
Yeah, hi, David Bryden with Results, and I'm really inspired by some of the things that we're hearing from Dr. Gallardo about integration, because I know it's so important. If you look at Mexico, for instance, there's such a comorbidity with diabetes and tuberculosis, and we see it on the border actually in Mexico and in Texas on the border, and it's a huge issue. It's called the looming epidemic actually. This comorbidity of diabetes and TB in Asia. So I guess my question to the panel, do you see opportunities with diabetes programs for instance, screening for TB? And is that a creative way to sort of bridge this NCD versus infectious disease divide?
Yeah, you make it. Other questions or comments before we move back to the panel? It's hard to see.
Another lady back there.
Hi, Peggy Knudsen, Friends of the Global Fight Against AIDS, Tuberculosis, and Malaria. And I see in your notes about your initiative here that you say a lot of the NCDs are endemic and likely related to infectious diseases, toxic household environments, and food insecurity. And I wonder if you could go a little bit more into how to address that vast circle of problems that we don't necessarily have in developed countries, and how to make this more of a holistic approach, because that's a lot of problem solving that needs to be done before we can really get at the heart of this.
Okay, so we've collected 3 questions there, one on remote diagnostics, one on integration, because clearly there's a big overlap between TB and diabetes, and one on the fact that usually non-communicable diseases mixed together with food insecurity and all sorts of problems. I mean, in South Africa they talk about the quintuple burden. So you don't have to answer, if not
all of them.
Four of you have to answer all 4 questions. But
I have a comment with what we just said, and up to now, based in 4 years of field work, we are really convinced that the access to broadband and internet is a must in the primary healthcare system, as well as important to have a stethoscope or to have primary healthcare basic drugs in the clinic is to have the broadband, not only for the health center, but also for the citizen. Actually, we have moved from the old paradigm of telemedicine to telemetry, meaning the normal citizen can run basic measurements at home or at the office or at the workplace, send the measurement, blood pressure, sugar, weight, to a specific cloud, and then have immediate response, as well as having all the information in the cloud for when he or she goes back to the clinic. So the old paradigm of being waiting to an appointment for your doctor once or 2 months, long lines, in order to find out what is the interpretation of the blood sugar. That is all for us. So that's to the first point. And I also would love to comment on what just he said. And that is why I hesitate to go back to vertical programs. Whenever I come to see a minister or a president, say, well, I will do a crusade against diabetes. I ask him, please be aware. Vertical program, to my point of view, is not the answer, such as complex conditions like NCDs that has to do with lifestyle. So integrated approach, being able to early detect not only tuberculosis, but for example, mental diseases within people who are having NCDs. Maybe it's the way how are we dealing with stress, for example, the reason why blood pressure and sugar are so high. Maybe we are not being able to detect because it's in the other department, in the other silo, in another program, in another republic, in the same minister, the Republic of Mental Diseases, and maybe that is why we are not being able to detect anxiety and depression, which, by the way, 80% of diabetic patients are not being detected, not treated, and that is the main reason why their sugar is not getting into control. So, as you just said, we have to move to be able to understand the person that we have in front. They may have tuberculosis. It's a severe problem because diabetic patients have a severe immunodepressed system. So tuberculosis and other chronic infectious disease usually comes together with those patients.
But Hex, can I ask you, I mean, in Mexico, you've simultaneously got very high levels of obesity and you've got undernutrition, yeah? So
Right.
how do you think about those problems together?
And actually, as you know, a pregnant woman who is undernourished will bring kids that later on will have diabetes. So to me, it's again 2 faces of the same coin. What you have to be worried on is better nourished everybody in the same city.
Evan, weigh in.
No, I mean, I'd certainly just to comment on the integration, and I speak a little bit from I practiced internal medicine, primary care for 10 years. So I think you can't argue with the need for integration because somebody who walks in the door could have any of a number of conditions. But I think that health systems has to be designed, and I'm a great believer in the power of information technology, which could empower a frontline healthcare worker to deal with a complex array of diseases, but I'm also sensitive to the overload factor and asking it, because it all comes down to that person you first see when you walk in the door. So these things have to be done intelligently and
So
appropriately.
you're for and against integration?
Well, no, I'm for it. I mean, I'm for it, but it has to be done carefully. And I think that technology is a very powerful tool that could empower the healthcare worker. Although what I've also seen in the field with respect to technologies, there's been in many countries a proliferation of cell phone m-health platforms, and that's been a big problem. There's a lack of standardization. And in the country of Uganda in 2009, prior to coming to Lilly, I think we were the second project that used a cell phone approach to use SMS, which is available on any phone for reporting of malaria. And 3 years later, I heard that there were 70 such projects in the Ministry of Health that actually stopped and not allowed any new project because of this proliferation. So that's just a caveat about the technology. And lastly, just because we have our MDR-TB partnership and the TB, MDR and the NCD partnerships, I have to comment, of course, on the TB and diabetes question, and just say, yes, we're very sensitive to it, but we also live in an environment where, as a pharmaceutical company with an active portfolio that does cover NCDs, we don't make any more drugs for MDR-TB. We sort of run up against sort of the concerns of the wider stakeholder community, I think, and this may be a factor for some of the other efforts in integration, which make it difficult for compliance reasons. So,
do you want to weigh in on this?
Well, Richard, when you think about the fact that 80% of the world's population lives every day on $10 or less, let alone those who live on $1 to $2, and yet some of the fastest growing mobile technology purchase and development is occurring within populations that have very little flexible spending. Do we know technology today as to what we need tomorrow? No, we're learning moment by moment, day by day. But what I think we are definitely needing to learn is that it's really not about the technology, hardware or software. It's always going to be about the people. So when we talk about shifting tasks to frontline health workers, a very, very important thing to consider. But in all reality, worldwide, the ones who give most care are actually voluntary care minders, caregivers, whether they're relatives, household members, neighbors, or what have you. And we have to keep them in the equation as well as how we make sure that we're equipping those who are providing care to those greatest in need, or helping individuals to find out whether or not prevention is the answer for them or further care or treatment. People are the center of it. And somehow or another, we've got to make sure that as we are strengthening health systems, we're continuing to remember that people-centered approach to the process.
Just to pick up also on this this point about integration, that I think there's still a lot of things that we're learning from these health systems as they develop, as they go from spending $7 per capita to $50 per capita, and then hopefully on to say $100 per capita. And I think that Richard, one of the points that you're making is, do we really want to reproduce the disaster that we have in the U.S. in terms of our health system, where we're spending $8,000 per capita with not as great outcomes as one might hope? And I think there's an opportunity from a health system design standpoint for, I think that what we're really talking about here is a kind of science of integration to understand how do you deliver these health services in an efficient way that covers the entirety of what people would consider obscene not to treat. And I think that that's what we have the opportunity to do. And it's very possible that we may be able to do that for as little as $100 per person per year, which, when you think of spending $8,000 in the U.S., that would be an enormous achievement if we can design health systems that can deliver what we would consider basic human rights, including many of the things that are excluded now. So I think that that's really huge.
And probably primary care is very important in that. So we've got about 7 minutes left. One way we'd like to shift the conversation to the role of the private sector, because I suggested at the beginning that perhaps the private sector has almost more to offer here than in almost any other area. So I wonder, any comments on that? Be also potentially interesting, is anybody here from a food company? Because there are great debates about the role of the food companies in all of this.
Back there's a question.
Yeah, I think she's good at spotting people.
Hi, Irene Klinger from Pahua. As you heard before, I'm not from the food companies, but I am accused of working with the food companies, so it's an interesting issue to talk about. I think when I hear you talk about risk factors, you talk about health determinants, you talk about integration of health systems, dealing with the person as a whole, etc., etc. All of that is music to my ears, and it's the discussions we have at WHO, we have at PAHO. I'm sure any one of you can work at PAHO or WHO and have done so in some part of your life or will do so at some point. But I didn't hear the other issue, what you just raised, the issue of the role of the private sector, and how do you really build these partnerships, this paradigm shift that we confront. We have a mandate. We all know we need a whole of society approach. We all know it needs to be multi-sectoral and multi-stakeholder. There is no doubt about that. If you want to reduce hypertension, you have to work with the food and beverage industry so that they reformulate products. And they are partners that need to be at the table. But how do you change paradigms in each of our institutions so that this dialogue is possible and going beyond dialogue to action? And I think you should maybe share with us a little bit about how you built your partnerships, what it took, how long did it take, and what lessons can be learned. Thank you.
Good. Well, thank you. That's a pretty crucial question. Do we have other comments or questions before we go back to the panel? Down here.
Hi, my name is Elizabeth McGregor Skinner with Abt Associates, and my question for the panel follows Dr. Klinger's comments that this is really a whole of society approach that we've been discussing. And the meetings in 2011 also brought that forward, the UN high-level meetings. But I think a lot of us here speak within the health systems context, and we're speaking about ministers of health, and we talk about leaders. How much are you all, both from the private sector, from the foundation side, how much are you engaging with ministers of social and economic development, ministers of finance, as well as other leaders in the country? Thank you.
Good. Well, I think those are really good questions to end with. I mean, this is crucial. There's certainly an important role for the health system, but if we really want to make a difference, we've got to get beyond that.
Well, I think that actually is they're both very consistent questions about partnerships, about the fact that it is multi-sectoral. It has to be. That we're talking about civil society together with public sector. The private sector really is, in fact, a member of community, no matter where we speak. Whether we're talking about the corporate individual or whether we're talking about the individuals that make up the corporation, we're all part of the same community. Each of those entities have motivations to why they want to be able to ensure the healthiest communities possible, and we need each one of those motivations for success. Now, in terms of the governmental side of things, I think it's very important that as we think of this as not only a health issue, but a social development issue, in many ways, I believe also a human rights issue to extent, that we have to engage other sectors other than only health.
So are you doing that?
Indeed. So when we look at the partnerships that we've been a part of, not only on the global level, and the high-level meeting I think was a great example of global partnership, but we try to bring now partnership to the national level. So as countries are developing their NCD plans and plan of actions and operations, that we can help convene, be a member of, partner, support local leadership on a multi-sectoral level. There are multiple barriers around that continuum of care that need partners from all sectors. And I think that their public sector counterparts as well as their civil society and private sector are needed. We have to be in a partnership that goes beyond health only.
So Evan, let's ask you, do you worry sometimes that it rolls off the tongue very easily, whole of government, whole of society, but making it happen seems to be hard?
It's a lot of work. I mean, from our own experience in designing the NCD partnership and choosing the partners, we really had to do a great deal of research on the ground to identify the key problems, identify partners who both had capacity to implement, but also the kind of standing that would enable them to get the ear of government and other key stakeholders when
So it's their job to get the ear of government, not your job.
Well, we work with them. I mean, we can support convenings. We do a lot of the things that Jacob just described as well. We could support high-level convenings. We can use our own relationships with government as well. But, you know, just through getting back to Irene's question, that was Dr. Klinger's question, that was really about choosing partners who can also have a synergistic effect in terms of the clout and getting the ear of government. And then, you know, building in a strong communications effort around that, and an all effort around websites and media work and journalists. It's all a very important part of getting the ear of the larger segments of society.
Hector, what wisdom have you got to offer us?
Well, I really think that is a must. Partnership and commitment, real commitment, is a must of any other people within the society, any other institution, whether it is public or private. It's an issue of partnership and commitment. We have done that with the educational sector. We should do that with the food industry. Just I bring to my mind an editorial of New England Journal of Medicine 2 weeks ago, talking about the access of healthy food and the risk factor for cardiovascular risk. Joe Loscalzo from Boston School of Medicine and Harvard School of Medicine wrote about how related is the access of bad food, processed food, and the high risk of cardiovascular risk. So if we don't tackle and we don't work together with the health industry, we don't partner with them in order to decrease the amount of processed food at a low cost, because it's initial cost, then we won't ever succeed. So it's a must for us.
Okay. Jean?
I think we're pretty close up
we
on
are. We're about
time, but yeah, I mean, I think on the one hand, my answer is that, of course, whole of society approach is important. I think on the other side, I think some of the things that were said earlier, that there is also an enormous amount that the health sector, in particular, can do in response to this, and in fact, I don't think that there's anything wrong with having action, particularly in very low-income countries, that's heavily focused on the Ministry of Health, when there's a very urgent need to address people that are dying from these diseases now.
Okay, let me end by saying, I mean, Georgia Lane, who I've quoted already, says that actually whether the private sector really gets involved with this is what's going to make a difference as to whether we can reduce the burden of NCD and achieve that target of reducing deaths under 70 by 25% by 2025. And on your tables, you'll find there are some papers about how Medtronic and Eli Lilly and others have got very practically involved in all of this. And perhaps I could end by on a sort of positive note. In Britain, because of a collaboration between the government and health people and the food industry, we have reduced salt consumption by 15%. And of course the average person in Britain has absolutely no idea that that's happened, because we've just done it very slowly. And that can make a hell of a difference, save a lot of lives. So I encourage all of you, we'll all be here during the breaks, think about how you can get involved in making a contribution to this. Thank you.
Thank you.
It's a really nice